All right, we're going to move on to our next portion of our CE event for the Keratoconus Symposium. And this is going to be presented by Dr. Kent Wellish, who is an MD here in Las Vegas. He's going to be talking about co-managing keratoconus. And one of my favorite things that he talks about is his dry eye passport, which he has actually graciously given us a copy of on the WooU website. So when you're going through this presentation and if you find it valuable, he has graciously given us that. So in case it could help you in your practice, I'm excited to learn from him. And it's now my pleasure to introduce our next speaker, Dr. Wellish. Dr. Wellish is one of the most experienced keratoconus surgeons in Southern Nevada. He completed a 2-year cornea external ocular disease and refractive surgery fellowship at Julestein Eye, UCLA. He became Nevada's first laser vision surgeon in 1994, and he's been performing corrective surgery on keratoconus patients for over 29 years. He's also a pioneer in emerging treatments for keratoconus, and he's trained surgeons from all over the country for the use of Intacs. He also served as an FDA primary investigator for the Avedro corneal cross-linking and has treated hundreds of worsening eyes with 0 eyes progressing on to needing a corneal transplant. That is absolutely outstanding. As an FDA primary investigator for many other technologies, Dr. Wellish is able to apply his insights from a variety of studies, as well as his clinical experience to develop cutting-edge protocols years before they make their way into standard teachings. As much as he loves and takes pride in being the best in class for treatment in patients, Dr. Wellish particularly enjoys training optometric externs from a variety of optometry schools. And Dr. Wellish was actually my very first site when I was an intern or extern at SCCO, and it was an absolutely wonderful experience, and it's been really, really fun to be able to come full circle from one of the externs kind of training underneath him, and now we co-manage many keratoconus patients together. So welcome, Dr. Wellish. We're excited to have you and excited for your presentation.
Good morning, everyone. This is Dr. Kent Wellish in Las Vegas, Nevada. And I've been invited to share, delighted to be with you today to share our insights on how to make sure all of our keratoconus patients preserve their useful vision through the early diagnosis and early treatment of this condition. Again, thank you to Wu University, and it's been a pleasure working with them as we educate ODs around the country. Our goals today are to talk about co-management and how it applies to keratoconus. We're going to talk about preparing the ocular surface for surgical success. It's imperative when it comes to keratoconus patients. Early detection and managing dry eye syndrome prior to corneal cross-linking, corneal inlays, and other corneal procedures is incredibly important in order to produce the best outcomes. In this course, we're going to learn about tips and tricks on diagnosing dry eye in keratoconus patients and effective treatment options. We're going to be discussing pharmaceutical options, nutraceuticals, punctal plugs, amniotic membranes, and much, much more. We're going to emphasize early detection and how to overcome the barriers to early detection. We just heard a terrific presentation from Dr. Mitch Eibach on the early keratoconus diagnosis to save vision. In my experience, today's optometrists have no problem identifying topographies suspicious for keratoconus. From what I can see, the main barrier is screening routine patients for earlier diagnosis and treatment. Patients who we don't even realize are at risk because they have a normal refraction. They don't look unusual. These people, in my opinion, should be screened. I'll explain why. And that big barrier is resulting in patients, when they're referred to me, of being more advanced in their keratoconus than I wish they were. Up until last year, we were all taught that the prevalence of keratoconus was about 1 in 1,500 to 1 in 5,000. This is all based on technology and studies in the 1960s using devices that were not the ones we have today. That all changed in April 2021 when the RAIN study in Australia found that the actual prevalence is 1 in 84 in 20-year-olds. It's probably higher in 25 or 30-year-olds. So we now know that at least 1 in 84 people age 25 have keratoconus. Well, I'm going to make some parallels and some comparisons between the national data and Clark County, where I live, Las Vegas, Nevada, because I want to show you how underpenetrated this market is for reaching and treating keratoconus patients is. The current population of Clark County is a little over 2.8 million people. So if you say that 1 in 84 have keratoconus, that means that there are about 34,000 people in the Las Vegas area with keratoconus. The RAIN study, published in our main journal, Ophthalmology, April of last year, used the pentacam, and they used the Schleimflug technology, imaging technology, which is the gold standard for detecting keratoconus. They looked at 1,259 participants, 20 years of age. It's a multi-generational longitudinal cohort study, and they used the Schleimflug imaging using the pentacam in Perth, Australia. What they found was that 15 out of 1,259 had keratoconus in at least one eye. That means the prevalence was 1.2% or 1 in 84. The mean corneal thickness in those diagnosed at age 20 with keratoconus was 475 microns versus 536 microns in normals without keratoconus. About half were women. Interesting to me was that the refractive cylinder was only 1.25 diopters versus a quarter diopter in normals without keratoconus. The mean keratometry of the steepest axis was 45 diopters versus 43.76 in normals. So if we're using refractive cylinder or keratometry to see who's at risk for keratoconus and only then testing those people, we're missing a lot of folks. Keratoconus was associated with regular cigarette smoking. 38% of people with keratoconus admitted to regular cigarette smoking versus 14.6% of non-keratoconus patients. There was no association with gender, race, body mass index, or pregnancy. There was no association of even using glasses or contact lenses, no association of a history of allergic eye disease. So if we're using any of these things to decide who we're going to screen, we're going to miss a lot of people. As the leading provider of cross-linking treatments with keratoconus in Las Vegas, we've been told we're doing more than half of all the treatments in Las Vegas. We've performed about 300 cross-linking procedures on about 175 patients. That is about half of 1% of the population who has keratoconus in our area. We've been told, again, that we do more than half of the procedures. That means that less than half of the keratoconus population has been treated. In our experience, about half of all keratoconus patients become unstable and worsen, but another half remain stable. Remember, just because someone has keratoconus does not mean they need cross-linking. It's only if they're worsening or becoming unstable. Therefore, using Las Vegas as an example, less than 1% of the keratoconus population has been treated, and less than 2% of those who have unstable keratoconus, those that need to be treated, only 2% have been detected and treated. The other 98% are just sitting there getting worse every day that goes by. When we see patients referred for the evaluation of keratoconus, the average best corrected spectacle corrected vision is worse than 20/60 and often worse than 2100. That means that we are not diagnosing and treating keratoconus early enough. We really should be detecting and treating it at the 2020 to 2030 stage so patients can drive without glasses and not be as dependent on advanced contact lenses solutions in order to function. 3 years before the RAIN study was published, there was another study presented at ARVO and published in July of 2018. It looked at the economic impact of keratoconus from a patient's perspective. This is Paul Baird's group out of Australia, in Perth, Australia. What he did was he looked at a cross-sectional analysis to evaluate the economic cost associated with keratoconus and to estimate the lifetime cost associated with keratoconus. Keratoconus patients were recruited from ophthalmology and optometry clinics in Melbourne, Australia. A keratoconus health expenditure questionnaire was given to patients to fill out to assess their direct and indirect expenses by these subjects, referring to their bills, receipts, things like that where possible. They had 100 participants who completed the questionnaire. Interestingly, their median age was 31. A little more than half were males. The average cost per keratoconus patient in the study that they self-reported was a little over $4,000 Australian dollars, which comes out to about 3,500 US dollars. At the time the study was published, the keratoconus prevalence rate was thought to be 1 in 2,000 in their report. And they said the cost to Australia was $40 million a year Australian, which is $32 million a year in US dollars. Well, since we now know that the prevalence is actually 1 in 84, not 1 in 2,000, that means the total cost in Australia in US dollars is more like $780 million in Australia. Since there's been no study like this done in the US, we still can apply some lessons of Australia to the US to make some inferences and to make some policy decisions. Well, if the population of Australia is 26 million, and the population of the US currently is estimated to be 334 million, and if you take the same assumption that the cost for keratoconus patients in the US, if you say it's about the same as Australia, $3,500 per year, and you do the math of 334 million Americans, 1 in 84 having keratoconus, that's 3.9 million people with keratoconus at a cost of $3,500 per person. That's anywhere from $10 billion to $14 billion a year that keratoconus patients have to pay these costs of for their care because of how we're doing things. Well, according to Zippia.com, there are 42,000 optometrists currently employed in the United States. So what does that mean? If you do the math, it works out to if you take $11.9 billion a year in keratoconus expenses from the keratoconus patient's point of view, that works out to about $285,000 per year in direct and indirect costs that these keratoconus patients are burdened with per OD by the fact that we're not diagnosing and treating it soon enough. So when we do cost benefit analysis, we all have to wear two hats, I believe. One, first and foremost, I see myself as a doctor as being a public health professional. I'm trying to make the public better. But two, if I don't pay my bills, I'm not going to stay in practice very long. So first, let's look at this from a public health perspective. What would it cost to greatly reduce the burden for keratoconus patients, this expense, and who should pay for it? Well, there are two approaches. What we've been doing for the past decade or two is we've been lobbying for insurance coverage and lobbying the topography makers to come down in price. And we keep on waiting for that to happen. And I got some live video footage of what that looks like. That's what it looks like. So we could still be there for decades doing the same thing. Or there's the other approach is we could take immediate proactive action. We can make ourselves action superheroes. This is the latest from CNN. It's actual footage of Spider-Man being sent to Ukraine to rescue them from an oncoming Russian missile and sending it back toward Russia. So how do you take action without waiting? Well, one thing would be to buy a corneal topography machine. The cost is $10,000 to $15,000. If you finance it over 5 years, the monthly payments are about $300 a month or $3,600 a year for 5 years. After that, the cost is next to nothing after that. This is a form called the Notice of Exclusion from Healthcare Plan Benefits. This form makes it ethical and legal to charge for a non-covered service such as screening corneal topography. It's available as a download through Wu University. If you look at this sheet, this is a generic version you could use for anything. What I would suggest is where it says list service procedure, you put in corneal topography. Where it says your doctor has recommended, you put in corneal topography to screen for keratoconus. Now, the reason why you would do this is they don't have a diagnosis. These people that you're treating, if somebody has keratoconus, you know that already, and you're already on the ball with that. I'm talking about the 1 in 84 that you don't know, and this is how you get them to pay for it. Cost I would suggest maybe around $29. So again, this makes it ethical and legal. This is provided through Corcoran, who's an advisory service for ophthalmology, how to do things to comply with all the different rules and regulations. So if you look at this cost benefit analysis from the point of view of the optometrist, if we're going to screen patients age 35 and under, which is my recommendation, in talking with ODs around Las Vegas, that seems like that's about a third of patients. In your area, it might be different. The average optometrist in the US, according to national studies, the average OD sees 62 patients per week, which is about 12 or 13 people per day in a 5-day week, or about 3,000 people per year. A lot of ODs in Las Vegas might see about 20 patients per day or 100 patients per week, which would be about 4,800 patients per year. So if you do the math, if you're going to screen a third of those patients, and then if 1 out of 84 have keratoconus, you're going to diagnose 12 to 19 keratoconus patients in the first year alone. And that's going to result in a savings of $42,000 to $67,000 per year, the rest of these people's lives, for patients with keratoconus through early detection and treatment. So if you're not seeing and diagnosing 12 to 19 keratoconus patients per year, then you're missing them and not diagnosing early enough to fully benefit them and save them from the lifelong costs over $3,500 per year the rest of their lives. So back to the cost benefit analysis and what ODs can do. Who should we be screening? I would start with every patient under age 35 initially, and then if it's normal, I would screen every 2 years until they're age 35. After age 35, if they don't have anything suspicious by then, I wouldn't worry. If they look suspicious for keratoconus, but they're clinically stable, you don't have to refer those people. See them every 6 months, but advise them about eye rubbing. Take a history. Know eye rubbing, how important that is. If you do have keratoconus that is worsening, you can refer ASAP if it becomes unstable based on corneal topography or other changes. So estimate is 1/3 of patients are less than 35 years old. Therefore, most ODs should be screening about 1/3 of your patients. The definitive diagnosis for diagnosis of keratoconus is the pentacam, and luckily we have that at our office if you're looking for a definitive diagnosis. So again, take action without waiting. After 5 years of your machine is paid off at $3,600 a year. After that, the cost is close to zero. So if you are seeing the US average of about 62 patients per week or 3,000 patients per year, that means screening about 1,000 patients per year and detecting 12 keratoconus patients per year. So what's that going to cost you? And is it going to be a money maker or a money loser? It's clearly a money maker for your aggregate patient base because you're going to save the keratoconics, that lifelong burden. So if you assume a capture rate of 80%, meaning let's say you could screen 1,000 people a year based on your average OD practice. And if 80% say, okay, I'll pay the $29, you're going to have 800 people paying the $29. Just as a matter of ethics, I do recommend that the other 20% you screen as pro bono. Don't charge them. Just have a sign a form that says they claim financial hardship. That way, if somebody comes after you, you can say, look, they said they had a financial hardship. And it's the patient's word. So the estimated number of keratoconus patients detected, 1 in 84, again, 12 to 19 in the first year alone. Your year one revenue on a $15,000 purchase would be $23,000. And then every year after that would be profit. Either your cost the first year is $3,600 per year, years 1 through 5. So your net profit in the first year is $19,000 per year or $1,500 per month. I'm not saying to do it for the money. I'm saying doing it to help patients prevent them from the keratoconus from getting worse through early detection. But for those of you that say, I can't afford to do this in my office, this shows you that almost you can't afford not to do it financially. So in the first year, you're going to net $19,000. In the second year and thereafter, I lowered it to about $12,000. Why? Because you're not going to screen every person under age 35 every year. You're going to shift to every other year. The ones that are suspicious, you'll screen more often. The ones that are new patients, you'll screen them the first time. So the benefit to the keratoconus patient through early detection and treatment is the aggregate of about $42,000 per year. In other words, all the keratoconus patients you're going to detect early and diagnose and get them treated early, you're going to save those 12 to 19 patients times $3,500, on average around $3,500 a year total between all those patients for the rest of their lives. So to me, that's what win-win looks like. So how do you take action without waiting? The most difficult challenges are mental, overcoming your current habits and inertia. Staff and doctor recommendations to all patients under age 35 to get this done regarding screening, corneal topography through a self-pay. Patient education really here is critical. So the most difficult challenges for all of us in changing a habit or behavior is mental. So what I would suggest is use your mental picture of those advanced keratoconus patients that we know we're going to see and that we wish we had diagnosed earlier as your motivation to overcome the above self-limiting barriers. If you need any support or suggestions on how to implement this, feel free to contact me personally at drwellish@mac.com. Saving and preserving eyesight of people with keratoconus is truly a passion of mine. I'm committed to doing whatever I can to support optometry and the keratoconus community to overcome all barriers to save keratoconus patients' eyesight at earlier and earlier stages. If done properly, this can and should be a win-win for optometry and for patient care. But you probably have a cross-linking surgeon in your area who you work with and you're comfortable with. Before calling me, contact your local surgeon, ask them to put you in touch with your local Glaukos cross-linking rep. There are reps in your area whose job it is to facilitate the process of cross-linking. Find out who your rep is. I know from a fact they'd be glad to talk to you I'm glad to help you implement these processes in your office, giving you all the training and resources that you need. So we've talked enough about early detection. Now I'm going to talk about making the surgery work better through pre-treatment with dry eye and other pearls. So to review the pre-op, we're going to be reviewing the pre-op care for patients being treated with collagen cross-linking. We're going to be sharing clinical pearls for targeted diagnosis and treatment, including indications. We'll be reviewing the evaluation by the primary care eye care physician. When people refer patients for keratoconus evaluation, typically they're telling the patient you may have keratoconus. Be careful not to tell those patients they actually have it, because you can show a topography that looks like keratoconus and you won't be able to tell by the topography alone that it's keratoconus. With keratoconus, there are things that we'll do at our office, such as looking at the elevated posterior cornea, whether there's epithelial thinning over the apex of cone. Those would be true keratoconus that you would not know that even if you had the best corneal topography machine. There's also pseudokeratoconus. In pseudokeratoconus, there is no elevation of the posterior cornea, and there's epithelial thickening over the apex of the cone. So it's not that uncommon that we see keratoconus referrals that turn out to be not keratoconus. So in order for us not to contradict you, you can tell the patient, this looks like keratoconus, but we're going to send you to our preferred surgeon or keratoconus expert for some further testing to see if it is. This is an example of an orb scan showing elevated increased posterior elevation. Normally, the maximum range is up to 40 microns of elevation. This patient has 213 microns of posterior elevation. So this is what you would see in true keratoconus. This is a OCT pachymetry with epithelial mapping. Again, looking at topography, you'd say it looks like keratoconus, and certainly over the apex of the cone, you see thinning of the epithelium. It's only 43 microns over the apex. In pseudokeratoconus, you have a normal posterior elevation of less than 40 microns. This one's only 16 microns. And in pseudokeratoconus, you may see epithelial thickening over the area of steepening, like you see here on the bottom right-hand corner. So again, caution your patients that it looks like it might be keratoconus. We're going to send them on for further testing. When cross-linking was developed and started in 1998 using the Dresden protocol, it was used throughout Europe or in limited areas, but then we tried to bring it to the United States, and the first time it was used in Las Vegas was in 2012 by us as part of being the FDA studies, the Avidro for keratoconus and for corneal ectasia. We're proud to tell you that we were one of the first sites to have a very high rate of follow-up, and our data and successful outcomes were instrumental in the FDA's decision to approve keratoconus here in the US in July 2016. I'm going to share with you now lessons that we've learned from Intacs and keratoconus. And basically, there's no excuse for just watching keratoconus and ectasia worsen. We now have great treatments and great early diagnosis and detection instruments. So keys to success, I would say, is the politicians say now follow the science. The science to me on dry eye follows the DEWS-2 study, the dry eye workshop DEWS-2. It's a few years out of date now, so we keep it updated. There are tools that you can also download through Wu University, but it's clear now that aggressive diagnosis and treatment of dry eye and meibomian gland dysfunction before cross-linking is critical to attaining good outcomes. By that, I mean also LipiView, LipiFlow, and IPL are important parts of this approach, along with the overall assessment and treatment plan outlined in the dry eye passport that we also will review with you, and it's available for download. I invite you to download these, customize these to your own practice, but patient education is critical. So the vast majority of patients will never need IPL, LipiFlow, or anything like that. They'll need nothing more than stage 1 or part of stage 2, DEWS-2 treatments. We start everybody that we see if they have any kind of staining on, which I'll go over how we detect that, with non-preserved artificial tears. The one I like the best is Oasis Tears Plus or Retain MGD. Also lid hygiene, hot compresses, omega-3s, maybe lacrimal plugs. But if that's not enough, they might need cyclosporin, they might need lifitegrast, they might need loteprednol 0.25%, the Isuvius, or they might need the new Tyrvaya nasal spray. 5 to 10% might need IPL, LipiFlow, serum tears, and/or amniotic membrane treatments to treat the pre-existing or resulting dry eye. It's well known that all corneal procedures can cause or worsen dry eye, so patient education is important to let people know about this. This is part of what is available for download, the dry eye passport. We show every patient this and go over it with them. And we show them that normal meibomian glands in the upper left-hand corner, when you blink, liquid oil comes out. But when the glands are blocked and there's no or limited secretions, that impairs the quality of the tear film. We also educate them that the normal meibomian glands look like long piano keys filled with oil. But if the glands are blocked for too long, those glands start to atrophy. They scar down, shrivel up, and go away. Once those glands are gone, that's it. We can't bring them back. So part of the dry eye passport involves this little fake map of the world that we made, where we tell patients that they live in a world where they ask if they heard of the country called Ireland. Yes. I say, well, you live in a country called dry Ireland. And you've heard of Greenland. We're trying to get to moist land. To get there, you got to go through certain countries first. You got to go through eye drop land, where you take eye drops, Pillistan, where you take pills, and home treatment DINA, we do certain treatments at home. There are certain procedures that might be covered by insurance, others that may not be covered. And we go over with patients that the keratoconus means the shape of the cornea is shaped like the tip of a football. And if you compare the cornea to a map of the world, if the world were only covered by ocean water, it would be perfectly round. But when you have dry land, it's above sea level, and that gets dry. Because their cone is above sea level, that's where it's more prone to get dry. And when we do the procedure, the best way to do it is epithelium off at this time, and it takes time for the epithelial cells to heal. And if we don't get the eye super moist before the procedure, delayed healing will lead to decreased vision and unnecessary complications. So we then move on to what I call the treatment of dry eye in 4 steps. Again, this is available for download, and this is all modeled after the DEWS 2 recommendations. We start with patient education. Every patient gets an eye trace and a lip review. We talk about the importance of dietary supplementation, including quality omega-3 vitamins, 8 cups of water a day, environmental factors that we want to modify, including being careful of ceiling fans, smoky environments. We talk about medications that are modifying factors, and high-quality artificial tears. My favorite ones for this realm is Oasis Tears Plus and Retain MGD, because they have some oils in there that don't blur the vision too much, but they last longer, and we emphasize the importance of taking these every 2 hours while awake. We also educate about the importance of blinking at least every 10 seconds, if not more, and closing their eyes all the way when they blink. We tell them that lacrimal plugs, we start them on hot compresses, as well as telling them that come back in a couple of weeks, we're going to check you. And if your eyes still have some SPK or staining on a test we're going to talk about called the 5-minute fluorescein test, lacrimal plugs will likely be needed at that next visit. We want these eyes, even the apex of the cone especially, to be super moist and have absolutely no staining at all. So with our protocol, 80% of patients that follow this protocol are ready and clear to go for cross-linking if they follow that protocol. Quality non-preserved tears such as Oasis Tears Plus or Retain, hot moist packs with a beaded mask, the microwave heat, high-quality omega-3s, and silicone lacrimal plugs if needed. These are all things that can be done by ODs if you have a level of interest. You don't need an MD to do these things. Next, if they come back and they still have staining, well, we can use topical anti-inflammatory drops such as Restasis, Cequa, and Xiidra. We also can do thermal pulsation with LipiFlow, even IPL. There's some newer treatments called Isuvis, which is loteprednol that we'll talk about. Loteprednol, also known as Isuvis, is a suspension formulation that's a proprietary mucus-penetrating particle technology that increases surface exposure to the drug. It's great for flares, especially. Preclinical studies of the 0.4 formulation showed that a peak drug concentration in the cornea and conj were 3.6 and 2.6 fold higher, respectively, than those with commercial loteprednol. In addition to having nanometer scale particle size and a coating that prevents adherence to mucins after administration, the drug can be stored at room temperature. Here's more information about how Isuvis works. This is the Ocular Service drug delivery using mucus penetrating particles, or MPP. On the top is the ocular surface showing the lipid layer and then secreted mucins. And then you get to the membrane associated mucins. And finally, in that purple area is the corneal epithelium. In traditional drug therapy, shown in green on the bottom left-hand corner, most drugs are bound to the secreted mucins and are cleared from the tear film without really reaching adequately the corneal epithelium. But when you use a MPP treatment, mucus penetrating particles such as those found in Isuvis, you can see on the right-hand side, they're penetrating the mucus. they're getting through the secreted mucins, and they actually do a better job of reaching the corneal epithelial cells and the conjunctival epithelial cells as well. So that's the rationale for Isuvis. For Tyrvaya or varenicline nasal spray, in our opinion, it's overlooked as a modality for dry eye. It's actually fairly effective if used properly, but it's a nasal spray, and it's important to take some clinical pearls. It's a highly selective cholinergic agonist that stimulates natural tear production, and it's useful in the treatment of mild, moderate, and severe disease. The mechanism of action is similar to the now discontinued TruTear that was made by Allergan, in that it activates the fibers of the trigeminal nerve in the nose in order to stimulate tear production. It's a nicotinic activator of muscarinic receptors. When it's properly applied in the nose, it activates the trigeminal nerve, which in turn sends signals to all three elements of the lacrimal functional unit: the lacrimal gland, goblet cells, and meibomian glands. This leads to a nearly instantaneous increase in basal tear production, and then you sneeze. That's expected. You spray one spray into the lateral wall of each nostril, not up in your nose like you would with other nasal sprays, but toward your ear, toward the lateral nares, toward your ear twice a day. Before you spray for the first time, the bottle needs to be primed. Make sure you're not pointing it at anybody, but you have to do 7 pumps and then you're good to go. Tyrvaya, like all nasal sprays, is actually designed to be delivered just below the inferior meatus, or about ½ an inch in, with the tip angled toward the ear as the same side as the nostril that you spray. Advise patients as a pearl, put your tongue against the roof of your mouth and slow down the flow in the back of your throat. This helps prevent and minimize burning in the back of the throat. When writing the prescription, be sure to dispense 2 bottles. That's enough to last about 45 days. If there's a pause in usage for more than 2 days, the bottle needs to be primed again, sometimes only 2 pumps. There are no special storage requirements for either samples in the office or at home, but use your judgment. Try to stay close to room temperature. As far as cost is concerned, the reason why we're liking this lately, even some more than some of the others, is the availability. The company has a generous program from now to the end of the year to help patients with commercial insurance get the first year of treatment at low cost. You can ask your local Tyrvaya rep for details. Unfortunately, there is no coverage for Medicare patients or Medicaid, so it's not even worth prescribing or talking about for these patients. There are some normal expected side effects. In the pivotal phase 3 trial, 82% of patients sneezed. This is a side effect you should inform every patient about. It is to be expected. When our doctors and office staff tried it out, we experienced burning in the nose and the back of the throat. That was pretty much it for side effects besides the sneeze. So who's a good candidate for Tyrvaya nasal spray for dry eye disease? First, I recommend using the DEWS 2 Step 1 treatments: artificial tears, lid hygiene, high quality omega-3 vitamins, environmental controls, etc. Then treat the ocular surface inflammation if needed. Then, if needed, use extended duration lacrimal plugs. Then be sure the meibomian gland function is being adequately addressed. And then, if more is needed, then consider the Tyrvaya nasal spray. The spray acts by stimulating the trigeminal nerve, which in turn signals to all 3 elements of the lacrimal functional unit. But if meibomian glands are clogged with solid oils from MGD, that critical part of the triad will be missing, and that missing link holds back the effectiveness. So please treat the MGD first. Another overlooked modality is something that is called the electric dry eye mask. You can look on Google, on Amazon, and find a variety of these. The electric dry eye mask is sort of like a DIY, do-it-yourself, low-cost LipiFlow or IPL, actually more closer to LipiFlow. And this is what the unit looks like that we use a lot of. And you get it for about $99 on Amazon. You can sell it out of your office, and you're not going to make money on it, but it covers the cost of your time. And what the patient does is he or she puts it on. So the settings go from 5 minutes to a half an hour, anywhere from low, medium, high, or high. Some excellent results start if using it for 20 to 30 minutes on medium high the first month or 2. Right after they use it, we recommend that they look at their face in the mirror, get some Q-tips, and roll the Q-tip from below their lid toward their lash line, or for the upper lid by under the orbital rim and toward their lashes to sort of milk out the oils. Doing this is sort of like a poor man's LipiFlow. Again, LipiFlow works great, but the cost per case can be considerable, several $100s at least. And this is something people can use in between the LipiFlow treatments, and sometimes as a step to avoid needing LipiFlow. It's like a do-it-yourself option, but I would suggest maybe considering this sometimes even before going to IPL or LipiFlow. Also, in the DUCE-2 study, and that we put in these 4 steps of dry eye treatment. Step 3, if somebody's still failing and we've tried all these other modalities, don't overlook the benefit of autologous serum eye drops. Our office managers arrange this. They get a 90-day supply and use every 2 hours while awake. Back to this one again, actually, back to the autologous serum. There's a company called Vital Tears. And if you look on this slide above where it says step 3, it says vitaltears.org. Take that down. You can contact them, and you don't need to be an MD. You can prescribe this out of your office. This is an incredibly helpful modality. It helps restore the ocular surface for those severe dry eye patients. Next, also as part of step 3, are scleral lenses. Scleral lenses is something that we don't do ourselves, where we refer out to optometry, but scleral lens is a step 3 treatment. It can trap the moisture on the eye and provides good vision for patients. Oral secretagogues, such as oral pilocarpine, are rarely used. You have to clear them with your primary care physician due to systemic side effects, but from time to time they might be needed. And then a step 4 treatment would be considered the amniotic membrane graft. We're finding a lot of success with one by a company called Opticite. It only costs about $250. The reimbursement's about $1,200 or $1,400. The learning curve is quite easy. Feel free to contact me or one of our optometrists, and we'll walk you through how to do it. But again, you're not doing this for the money. You're doing this to help patients. There are practices that go to the amniotic membrane almost right away. In my opinion, that's really not the way to do it. You really want to stick to the DUCE-2 guidelines and go through the previous steps first. This is a reason why the patient can't tolerate or can't afford the others. One big advantage of the amniotic membrane is that it's covered by insurance. And again, this one that we use by Opticite is very well tolerated. So in today's day and age, there's really just no excuse for just watching keratoconus and ectasia worsen when we now have great treatments. Aggressive diagnosis and treatment of dry eye and MGD before treatment is critical to attaining good outcomes. LipiView, LipiFlow, and IPL are important parts of this approach, along with the overall assessment and treatment plan outlined in our dry eye passport. On the bottom left is what a picture of what good meibomian glands look like. The bottom right is meibomian glands with 25 to 50% dropout. On the bottom right is 75 to 90% dropout. We want to get these people sooner rather than later. Now I'm going to talk about the 5-minute fluorescein test. This is a commonly overlooked test that I would suggest that you make sure your surgeons are doing, because this helped us reduce our loss of best spectral corrected acuity from the 8 to 10% range found in the FDA study. Now we're at about 1%, sometimes less. So many cases of dry eye are missed because of delayed corneal staining. There's no visible, you put the fluorescein in, and if it's really dry and there's staining, yes, we're going to catch those. But a lot of times we think their eye is in good shape, as we did in the FDA study, but really there's no visible staining immediately after the fluorescein. But if you have to close their eyes and wait for 5 minutes, you see there can be significant corneal staining. So many cases of clinically significant dry eye are missed unless this test is rigorously performed pre-op. So if we see the staining in our exam lane when we first meet the patient, there's no reason to take the time. But if we're convinced they're cleared and good to go, this is one final step that we do that really keeps us from missing those cases. And that's a part of what we attribute our great results to. This test is above and beyond the standard of care, but failure to perform this test results in delayed epithelialization and therefore increased corneal haze and decreased best corrected acuity. So why do we do it? Because it lets our patients know that something even more important than just doing their cross-linking is important to us. It lets our patients know that literally we've got their back. Now, again, in the FDA study, 8 to 10% of patients lost one or more line of best corrected spectral acuity. Although the results were good enough to gain approval, we felt that loss of that acuity was an unexpected disappointment. And looking at my data, we saw this occurred with those with delayed epithelial healing. So these patients were not cleared for surgery if they had dry eye that was detected using regular techniques outlined in the FDA study, and unless they were adequately treated pre-op with no fluorescein staining on pre-op. So in the FDA study, including ours, the protocol clearly missed something because we identified and treated dry eye patients with what we knew at the time, and we followed the protocol, but shortly after the study started, we were invited to be part of another FDA study for a dry eye treatment that was later called Xiidra. In the Xiidra study, the protocol required judging corneal staining immediately after instilling fluorescein, and again 5 minutes later after instilling the fluorescein. We were surprised at how often that patients with little to no staining immediately had staining after 5 minutes. So it's easy to see how this undetected staining could lead to delayed epithelial healing and hence corneal haze and decreased best corrected visual acuity, best spectacle corrected visual acuity. You see these slides on the bottom left where the epithelial defect is taking slow to heal, and the final result, it does heal eventually, but now you got this beautiful corneal scar and haze. And in my opinion, there's really no excuse for this happening if we follow the protocol that I'm describing. So we theorized that if we added a 5-minute fluorescein test to our pre-op clearance and follow the DEWS 2 study recommendations in order to achieve complete lack of corneal staining in the area of the cornea to be debrided and treated, we could prevent the loss of best corrected spectacle vision. So today, after treating over 300 eyes with our protocol and a few other surgical pearls that we developed and adopted based on our observations, we're aware of only 3 patients, which is 1%, with a very slight loss of BSCVA with no need for retreatment at present. 2 out of those 3 admitted they're still rubbing their eyes. We tell them, no, you got to stop doing that. If there are 1 or 2 that we don't know about, we're still at about 1% versus the 8 to 10% in the FDA trial following the on-label FDA protocol. We have many patients who actually gained 1 or more lines of BSCVA. This is especially gratifying when we consider that all treated patients were actually worsening and unstable prior to their cross-linking treatment. In conclusion, we've all waited many years for the FDA approval. Now that cross-linking has been approved and available for the past 6 years, there really is no excuse to delay diagnosis and treatment. So please write down your action plan today. I would say get a pad and paper and do it right now as I'm talking. First thing I would do is please download the support materials that I provided to Wu University. Customize your own notice of exclusionary healthcare benefits to your practice and the use of corneal topography as a screening test for early detection of keratoconus. Develop your own protocol on how to explain to patients and parents the need for this screening. Get comfortable with the idea that you will be screening patients and charging for the screening using the NEHB form. You may want to consider a fee of $29 per test. You can decide what's appropriate for your area and your time. You decide who is suspicious for keratoconus and who is stable and who is unstable. Advise any keratoconus suspect patients or keratoconus patients the importance of no eye rubbing. We see people every day who said, yeah, they said I might have keratoconus 5 years ago. I kind of lost touch with my optometrist. And I say, well, are you rubbing your eyes? Yeah, I rub my eyes. And so people it's not really ingrained into them like it is to us, the importance of no eye rubbing. So with the diagnostic and treatment tools we now have available, there really is no excuse to delay diagnosis and treatment. We want to thank Avidro for bringing this technology to the US and making it available to our patients. Thank you for attending our educational program today.
Awesome. Well, thanks so much, Dr. Wellish. And, I know you're on vacation, so it means so much to the entire WooU audience that you would take time out of your vacation to educate us on keratoconus and just all of your pearls, especially on all of the dry eye management. It's such an honor to have you today.
Oh, glad to be here. Thank you for inviting me and glad to be part of this.